Good evening, dental internet world. My name is Dr. Vishal Sharma, and I'm once again here alongside my friend and co-podcaster, Dr. Mike Parchewski. You were discussing some aspects on implants, PRP, PRF, and we're going to switch focus right now to discuss that right now. Mike, if you're game for a little bit of a Q&A session, what do you think?
Sure.
Why don't you walk us through what those things are, Mike? What's the difference between them? And we'll start with that.
Sure. So again, a topic, platelet-rich plasma, platelet-rich fibrin, has been around in dentistry for a long time. And, actually most of the original literature came from dentistry. Whitman was one of the researchers. You had Marks, you had Whitman, you had Arun Garg, a lot of the pioneers in the early 2000s that were using PRP and PRF, primarily PRP at that time, for therapy, for regeneration, for cancer resection patients. And they found that was a way that they could get actual bone growth on titanium bars that they were replacing mandibles that were removed. And you fast forward to today, and it continues to be something that is ever growing market. Health Canada had a couple of years ago put a sort of a halt on PRP, PRF in Canada for all of professions because the literature wasn't there for hair. The literature wasn't there for certain therapies. And within 30 days, dentistry was allowed back into full access and full usage because we've got thousands of papers, thousands of literature behind it. But I think that moment in time sort of quashed, and then COVID hit. And so you found that the PRP, PRF sort of lost a lot of its luster.
Yeah.
Access to the machines has been tough now, access to centrifuges and test tubes. And because of the healthcare push, there's a lot of test tubes that are back ordered. So supply demand has really made access to using PRP, PRF tough. And I'm hoping this year that can turn around. And that's one of the reasons we wanted to talk about it today, because, we feel it's an important thing for dentists to learn and to be a part of, and using for their patients for the regenerative ability and making your socket preservations and implant cases better. So that's kind of one of our purposes, right?
And so where do you use it? Obviously, implants is the big umbrella for that. But walk specifically through the process, Mike, is in terms of when are you using it? When are you using it with socket preservation? When are you using it in conjunction with an implant being placed at the time of placement? And when are you utilizing it to augment a soft tissue deficiency? So socket preservation to start.
So if we just think about like what PRF is platelet-rich fibrin is when you have actual you're not using an anti-clotting agent and you're using a regular glass test tube. So you end up with a fibrin clot that you pull out, and that fibrin clot you can either compress it into a ball to use it as a socket plug, or you can flatten it out and use it as a membrane. As a membrane, it's pretty remarkable material. You can actually hang, hemostats off of it, and it'll hold up a hemostat. So that's how strong that is. Now, it's really a soft tissue regenerative material, and it's been proven that the bone regenerative capacity is helpful, but bone regeneration in a socket really requires a guided regeneration principles. So what you need is isolation of the soft tissue. So regardless of what you're putting in the socket, in order to get bone to have time to regenerate, you need to isolate the soft tissue from invading. So if you place in a socket just PRF, you still need to cover the top of that socket with a membrane and then maybe a layer of PRF over that, so that the soft tissue closes, but you still have a long-standing membrane there to allow the bone to regenerate inside, or the soft tissue is going to end up invading into a coronal portion of that, and so you won't get as much bone fill. So regardless of what we use, the benefit of PRF is really good for soft tissue regeneration, but whatever we do from a bone regenerative standpoint, we still have to consider keeping that space available so that the bone regeneration can occur prior to soft tissue invasion, because soft tissue invasion is much faster.
Yeah, so that's where you're utilizing it, I guess, in socket preservation. Walk through where you're utilizing it with the actual implant placement. So where you're, go ahead.
Yeah, so in socket preservation, exactly what we would do, where would we use it? So let's say we had a buccal defect, hole that where the fistula was open. You could take and put, you could bone graft it if you wanted to use like a cortical cancellous mix, bone graft it. And you're going to mix some PRP with that. You place that in the socket. You can use the PRF over the opening and then just close over that. One of the best purposes, the best usages of PRF is to protect your membrane. So a lot of membranes have trouble if they are moved, and so tacking helps things like that. But if membranes move, then membranes will fail. Well, the nice thing about PRF is because it's a clot, it helps to stabilize soft tissue movement. So if you place a membrane over a defect, then you could place the PRF over top of that and then let the flap close over that. The PRF helps to heal quickly and hold your membrane. So I like to call it a membrane protector, and that's what we use it a lot in that. Now, same thing goes with implants. So if you're placing an implant and immediately you've got a gap, right? You've got a gap around your implant. So you can mix some PRP, some sticky bone, works great. But you also might want to use like the PRF at the top to help protect the top of the implant. So you could put the PRF at the top, put a membrane over if you're closing, or just put the PRF at the top, graft the gap, put the PRF over, suture it close, custom healing abutment, and you're good to go. So we use a lot of the PRP for the bone, for the sticky bone, and then we're using the PRF primarily to protect the membrane and to replace where there's tissue deficiencies.
That's an apt, great description. So to further elaborate on that, when you're utilizing it as the term you used, a membrane stabilizer, now if you're covering the membrane with PRF and then having closure over top, is that then a resorbable membrane?
Yes, resorbable membrane.
And so typically what are you using in that scenario?
We use the Ossix membrane, and we'll also use, if we're trying to grow a little bit of bone, a Volumax, the Ossix Volumax. The Cytogenics has some great ones. There's a lot of Geislick's got some good ones. There's a lot of good ones out there. Most of the resorbable membranes are very similar. So you kind of have to find something that you like its functionality and placement. And certain membranes you're able to tack. Certain resorbable ones you can tack, and certain ones just fall apart when you start tacking them. So you have to, follow the manufacturer and then be aware of that. Do I tack a lot? Not a lot. Often I'll do like internal suturing of the periosteum to hold the membrane, and do internal suturing followed by external suturing. I don't use tacking a ton, but that being said, what I'm mainly doing is regenerative dentistry, implant dentistry for like 2 implant sites, not massive procedures. I've got periodontists that I work closely with that are phenomenal at a full arch where they're gonna have to take somebody who's been in a denture for 40 years and they've got to rebuild that. I'm talking about a patient that's been missing 2 teeth for quite a while and we're rebuilding. Those are the types of cases that I like to do.
And so walking through how obviously you're going to do a blood draw, but what's the processing aspect? You discussed how some of the centrifuges are a little more challenging to order now. Tubes have been a premium over the pandemic as well. So walk us quickly through that process.
So there's 2 types of tubes that we use. There's been all kinds of tubes in the literature, but right now there's really 2 tubes you need. One is a red top, which is a glass test tube with no chemicals in it, no coatings, and then a white top test tube, which is a plastic PET test tube. So plastic test tube, again, no chemicals. So what happens is the glass of the test tube has silica in the glass, and silica stimulates the clot formation. So when you centrifuge blood in a glass test tube, it'll trigger coagulation. Okay. The other thing that triggers coagulation is the presence of oxygen. Okay. Now the second way to get the second test tube we talked about is the white top test tube, which is plastic. So automatically you're thinking, there's going to be no silica there, so therefore you're not going to get clotting. Well, that's what we're using for the PRP. That's what we're using for the sticky bone. That's what we're using because there's going to be a delay in the clotting cascade. So what we can do then is draw out PRP. We can take that PRP level. So it's going to be between the buffy coat and the red blood cells. You're going to have that layer that is your platelet-rich plasma, and it will hub up to the first layers of red blood cells. Then we're going to take that. We're going to mix that with our bone graft, and then the presence of oxygen will then create over 5 to 10 minutes a clotting cascade that will occur, and lo and behold, you'll have sticky bone. So that's how we go the sticky bone route, and the red top will give us the PRF, which we make the membranes out of. But that's the only 2 test tubes you need.
And so you're obviously utilizing this heavily for implants, socket preservation, augmentation, bone grafting. What future applications do you see with this for dentistry, Mike?
A lot of research, PICOS and a lot of the perio gurus out there have been doing a lot of work on comparative results with, moving, like doing connective tissue grafts for coronally positioned flaps versus using PRF. The results so far in the literature have been comparable. So, there's not a benefit to say I'm going to use PRF over connective tissue, but sometimes maybe you can utilize the PRF to help when a patient is averse to the connective tissue, or whether there's more risk of morbidity in a patient based on health issues. So I find that the PRF has been really cool because you've got a lot of the immunoglobulins in there, and it's been really cool in the fact that in a lot of cases that we use it, we get a lot better post-op results. And I believe that's because you're using the immunoglobulins, you're using the patient's cells, and so you're fighting infection right there. You have antibodies in there that are fighting infection, you're good to go, so that when you're using it in sites that maybe have recurrent infection around a failing root canal tooth that you extract, I feel that your graft has better chance of succeeding when you involve that, right? So I just feel that it augments and helps, and I think we're going to continue to see that being used. And another place I see it being used in periodontics is like pinhole surgery, because it helps to stabilize the clotting and stabilizing, because one of the problems with pinhole is membranes don't like to be moved. And so if you go in and you do all that and the patient then scratches their upper lip, well, they can move that membrane. But if you've got the PRF, so what we do is we line some PRF first, then put the cut membranes, then PRF. So now what you're going to do is you're going to get fast healing of the gum tissue at the coronal portion. Then you're going to get your long lasting in the center where you want connective tissue formation. And then you're going to get fast formation of clotting underneath that's going to stabilize it. So that keeps things from moving. And the results are actually quite astoundingly better.
Yeah, I remember quite a while ago you were going through that sandwich technique with me, because of course Mike and I both do pinhole. And of course, the cost of those collagen strips is also prohibitive. So that was one of the suggestions you had quite a while ago. And so, Mike, you're going to be offering some PRP/PRF courses at some point. So more to discuss on that. Exciting 2023 planned for us.
Yeah, lots going on.
Lots going on. We'll wrap up on that component. Thanks once again, everyone, for listening. Wishing you a happy new year, and we will see you at podcast.
Right on. Thanks, everybody. Remember, like and subscribe. And anybody's looking for us, Digital Dentist on YouTube, at Digital Workflow Dentistry on Instagram, digitalworkflowdentist.com. Anything you need, let us know, and we'll be happy to help you out. Thanks, guys.